Estimados colegas, buenos días o buenas tardes. Mi nombre es José Villier y soy profesor y jefe del Departamento de Neurología en la Universidad Loyola en Chicago. Les voy a solicitar su compasión porque voy a hacer esta presentación en inglés. Dado la limitación del tiempo, me va a resultar mucho más fácil dar esta plática en inglés que en castellano. Los objetivos are to highlight the risk factors for intracerebral hemorrhage, probably touch upon very briefly about imaging predictors of a hematoma expansion, and to concisely summarize current management guidelines and ongoing controversies. When we refer to spontaneous intracerebral hemorrhages or parenchymatous hemorrhages, we are talking about the second most common type of stroke. Most of these hemorrhages, like is the case with ischemic strokes, are supratentorial, about 85%, with infratentorial representing about 15%. The most common locations in the supratentorial compartment include the putamen, the subcortical lobar hemorrhages, thalamic hemorrhages, and less common caudate hemorrhages. In the infratentorial compartment, the most common locations are the cerebellum, the cerebellar hemisphere, and the pons. Intraventricular hemorrhages may be secondary to a parenchymatous hemorrhage, rupturing into the ventricular system, or it can result from a primary intraventricular hemorrhage. As I said, this is the second most common form of stroke, with an estimated annual incidence of about 12 to 15 per 100,000 in the United States, and about 100,000 people in the United States annually, with an estimated 2 million people worldwide. This is a condition with a high risk for early neurological deterioration, having observed hematoma expansion in about 1/3 of the patients. Thus, an intracerebral hemorrhage has the highest rate of morbidity and mortality rate of all strokes, and many patients either die or are left seriously disabled. It has been shown that about 2/3 to 88% are dependent on others for activities of daily living 6 months after the index event. The 1-year mortality rate has been estimated to be about 50%, with a range of 30 to 50%. Epidemiologically speaking, the incidence increases with age. There is a higher incidence among African American men and women, as well as a higher incidence in people of Asian ethnicity. A spontaneous intracerebral hemorrhage is a dynamic process, and the role of thrombin in perilesional edema is the source of many investigations. I will show you classical pathological examples of a putaminal hemorrhage, a fresh putaminal hemorrhage, a thalamic hemorrhage rupturing intraventricular system with a true tamponade of the ventricular system, a caudate hemorrhage rupturing into the frontal horn of the lateral ventricle, a massive pontine hemorrhage, a cerebellar hemorrhage where the epicenter is in the area of the dentate nucleus. What are the etiologies of spontaneous intracerebral hemorrhages? By far the most common is hypertensive vasculopathy or hypertensive arteriopathy, leading to the rupture of small thin wall arteries that arise directly from larger arteries like the lenticulostriate branches of the middle cerebral artery or basilar artery penetrators. This hypertensive vasculopathy is due to the rupture of small caliber cerebral vessels known as type 1 arteriolosclerosis that typically affects small diameter vessels in half of the cases. In addition to this arteriopathy, there is a number of conditions that can be categorized under macrovascular etiologies that account for 15 to 25% of cases. And these vascular malformations, meaning brain arteriovenous malformations, are the leading cause of intracerebral hemorrhage among young adults. In addition to brain AVMs, under macrovascular etiologies, we need to consider brain aneurysms, dural arteriovenous fistulas, cavernous malformations, and cerebral venous sinus thrombosis. So number one in the list of etiologies is arterial hypertension with hypertensive microangiopathy, followed by vascular malformations, including aneurysms that can be saccular, infective, traumatic, or neoplastic. This is an example of a pericallosal aneurysm that rupture. Whenever you see this pattern on the CT scan, you must always obtain imaging of the blood vessels because this is not the location of a hypertensive bleed. Among the vascular malformations, we include arteriovenous malformations, cavernous malformations, and developmental venous anomalies that are often associated with cavernous malformations. Likewise, we need to include the capillary telangiectasias and the dural arteriovenous fistulas. The brain arteriovenous malformation will be the most common type of vascular malformation. In 80% of cases are supratentorial. The territory of the middle cerebral artery or the middle cerebral artery contributors to the AVM are most often involved. As you know, there is a need to recognize the nidus, the feeding vessels, the feeding arteries, and the draining veins. Brain arteriovenous malformations can be high flow or slow flow, and they may present with seizures, headaches, parenchymatous bleed, or still phenomena. The location is very important whenever we consider the risk factors of a given arteriovenous malformation for bleeding. And that includes deep location or ventricular, periventricular location, or location in the posterior fossa. In addition, other risk factors for bleeding of an AVM include the presence of an intranidal aneurysm, deep venous drainage, and high feeding arterial pressures. Dural AV fistulas are more common in the elderly, more common in women, more commonly intracranial. They are slow flow fistulas. They represent a diagnostic challenge and account for 6% of the supratentorial vascular malformations and 1/3 of the infratentorial vascular malformations. The rate of bleeding depends on the stage of the dural AV fistula. Brain cavernous malformations account for 10 to 15% of central nervous system vascular malformations. They may be sporadic or familial. They may be multiple in about 1/3 to half of the cases. There is no normal brain. They are low flow, low pressure malformations. The bleeding is predominantly within the malformation, rarely in the adjacent brain. The iron pigment from the bleeding is toxic to the brain, and that can account for the high rate of seizures, and oftentimes they are associated with developmental venous anomalies. The features can be very characteristic, but certainly there is a need for a differential diagnosis, as sometimes metastatic hemorrhagic tumors or infectious process may be confused with cavernous malformations. The developmental venous anomalies should be considered like an exaggeration of the normal venous structures draining normal cerebral tissue. They are commonly associated with cavernous malformations, and it's better to leave them alone. The capillary telangiectasias are generally asymptomatic, are most commonly found in the pons. They rarely bleed. Another etiology includes the protean bleeding diathesis, from leukemia to thrombocytopenia, DIC, polycythemia rubra vera, hemophilias, genetic or acquired hypoprothrombinemia, afibrino or dysfibrinogenemia, selective factor deficiencies, von Willebrand's disease, sickle cell disease, antiplatelet, anticoagulant, or thrombolytic therapy. In the case of leukemias, the parenchymal hemorrhages are multiple, predominantly in the white matter. They correlate very poorly with thrombocytopenia, but rather they correlate with a high white blood cell count with leukostasis, and are mainly found in cases of a blast crisis, for example, in acute lymphocytic or lymphoblastic leukemia. This would be very rare the case in the chronic leukemias. When we refer to oral anticoagulant therapy associated intracerebral hemorrhage, the anticoagulant per se is not the cause of the hemorrhage per se, but rather the anticoagulant promotes and exacerbates the microbleeding in the presence of small vessel disease. The hematoma expansion is quite common in about half of the patients in cases of anticoagulant-related bleed, and may be delayed up to 48 hours. The presence of a fluid level within the hematoma on imaging studies is quite frequently observed under these circumstances. Taking into consideration those patients receiving warfarin therapy, you will see that the majority of intracerebral hemorrhages occur within therapeutic ranges of the INR, between 2 and 3. A prior history, a history of a prior stroke, whether ischemic or hemorrhagic, or the presence of markers of cerebral small vessel disease like microbleeds, or the concomitant administration of antiplatelet agents increases the risk for bleeding with oral anticoagulants. Likewise, the presence of the epsilon 2 and 4 alleles of the apoprotein is associated with an increased risk of lower oral anticoagulant-related intracerebral hemorrhages. Here is an example of a man with multiple vascular risk factors on warfarin due to atrial fibrillation with an INR of 3.3, who had a massive lobar hemorrhage extended subcortically with penetration into the ventricular system and evidence of transfalcine and uncal herniation. Here listed are the hematoma rates in major clinical trials of thrombolytic therapy, and as you recall, in the case of the NINDS trial, symptomatic intracerebral hemorrhages occurred in 6.4% among those on therapy compared to 0.6% among those with in the placebo group. This is a case of a patient who was treated with streptokinase many decades ago due to pulmonary embolism and had multiple bilateral supratentorial hemorrhages. This is an example of a thrombolytic related bilateral hemispheric hemorrhages with fluid level and considerable amount of edema. In addition to the previous etiologies, we have to consider the vasculitis, whether infectious in nature or necrotizing, or vasculitis associated with collagen vascular diseases or systemic diseases. And let's not forget the giant cell arteritides like Takayasus and temporal arteritis. In addition, hypersensitive vasculitis may present at times with hemorrhages, and the same is true, although this is very rare, with primary angiitis of the central nervous system. Without discussing in too much detail moyamoya disease, we all know that the adult form of moyamoya, the phenotypic presentation in the adult may be with hemorrhages, including intraventricular hemorrhages. This particular patient had evidence of ischemia and necrosis of the digits, a foot drop, and a lateral malleolar ulceration, and a foci of hemorrhage on the CT scan or hemorrhagic infarction, leading to one to suspect that the combination of CNS and peripheral nervous system manifestations may be related to a systemic vasculitis, and that was a case of a rheumatoid vasculitis. In this case, the source of the hemorrhage was a fungal infection with aspergillosis. Drug-related hemorrhages include particularly the sympathomimetic agents like amphetamines, cocaine, phencyclidine, and many others. Cerebral amyloid angiopathy is a common cause of lobar intracerebral hemorrhage in the elderly. The phenotypic presentation is quite protean, with the occurrence of lobar intracerebral hemorrhages, lobar microbleeds, cortical superficial siderosis, leukoariosis, microinfarctions, and let's not forget the inflammatory form of cerebral amyloid angiopathy, including the rare condition known as ABRA or A-beta related angioitis. These are examples of patients with a cerebral amyloid angiopathy with recurrent lobar hemorrhages. And the epsilon 2 and the epsilon 4 alleles of the apolipoprotein E have been associated with the severity of the cerebral amyloid angiopathy, with this particular genotype can help to identify patients with lobar intracerebral hemorrhage at highest risk for early recurrence. Intracranial tumors, whether primary malignant or benign, or more commonly metastatic tumors, hemorrhagic tumors like those deriving from melanoma, renal carcinoma, or thyroid or choriocarcinoma, may account for hemorrhagic metastases. These are the examples of multiple hemorrhages in a patient with metastatic melanoma. This is a patient with bilateral lobar hemorrhages with metastatic choriocarcinoma. These are patients, this image pertains to a patient with bilateral parasagittal confluent hemorrhagic infarctions due to a superior sagittal sinus thrombosis. Other etiologies of spontaneous intracerebral hemorrhage include reperfusion syndromes following carotid endarterectomy or angioplasty stenting, as well as other surgical procedures. Rarely, an intracerebral hemorrhage may be related to cold-related exposure to low temperatures, lightning stroke, heat stroke, fat embolism, after painful dental procedures, rare cases of protracted migraine, probably representing reversible cerebral vasoconstriction syndrome, as well as methanol intoxication that may have an affinity to the putamen and therefore be confused with a hypertensive putaminal hemorrhage. Here we see a patient with fat embolism, probably related to a long bone fracture. Due to the limitations of time, I am not going to review for you the algorithmic approach to the investigation of these patients, just highlight the importance of the spot sign that can be an area of uni or multifocal contrast enhancement within an acute spontaneous intracerebral hemorrhage, visible on CTA, with a prevalence is about 1 out of 4 patients, with a sensitivity of 62% and a specificity of about 88%, and considered to be a risk factor for hematoma expansion as well as poor outcome. Few words about treatment. This is the less treatable form of stroke. As to the date, there is no therapy of proven benefit in improving outcome. Various methods of surgical hematoma evacuation have yielded either negative or inconclusive results, and no medical therapies have been shown to conclusively benefit patients with intracerebral hemorrhage. The goals or the principles are to slow the bleeding, to reduce the hematoma expansion, to improve intracranial compliance, and reduce intracranial pressure. Obviously, patients' parameters like blood pressure, blood sugar control, prophylaxis of venous thromboembolism, management of seizures, if present, are certainly important components of the overall management of these patients. It's quite common to observe in the acute period of an intracerebral hemorrhage an elevation of the blood pressure, and that hypertension has been associated with a greater risk of hematoma expansion and mortality, as well as a worse prognosis for neurological recovery. Different recommendations for blood pressure have been provided. Certainly, a number of clinical trials have been, to say the least, inconclusive. I am going to briefly review that hemorrhages associated with the administration of anticoagulant therapy, either heparin, oral anticoagulants, either vitamin K, antagonists, or factor Xa inhibitors, or thrombin inhibitors, should be treated accordingly to standards. For heparin and unfractionated and low molecular weight heparin, in patients who receive vitamin K antagonists, the main therapy includes vitamin K and the administration of prothrombin complex concentrates rather than the conventional vitamin K and fresh frozen plasma. We have now reversal agents for the DOACs, certainly idarusizumab for dabigatran and andexanet alpha for the factor Xa inhibitors like rivaroxaban, apixaban, or edoxaban. But if andexanet alpha is not available, prothrombin complex concentrates should be entertained. In the case of hemorrhages associated with thrombolytic therapy, the recommendations are to administer cryoprecipitate with or without other agents like tranexamic acid. Remember that the administration of platelet transfusion has been shown, at least in the patch trial, to account for worse outcomes. In the case of hemophilia, factor replacement should be obvious. In the case of idiopathic thrombocytopenic purpura, in addition to platelet transfusion, systemic corticosteroids and or plasmapheresis is indicated, and in some instances, splenectomy may be required, and obviously cases where the hematoma may need to be evacuated. The topic of surgery will take me another hour, but this is just to show you that in essence, all the clinical trials since the 1961 trial by Makisog, followed by the 1989 trial of our same year Juvela, the Stitch and Stitch 2 trials, and the Misty 3 trials, at least the way we understand the primary outcomes, there is thus far no convincing evidence of benefit with surgery for supratentorial hemorrhages. Certainly, currently people are more interested in the minimal invasive surgical techniques, but the interpretation of the published studies is that at least there is no evidence of clear benefit for these minimal invasive surgical techniques in relationship to improving disability after supratentorial hemorrhage. In the Misty 3 trials, the clinical current guidelines do not support the routine supratentorial brain hematoma removal, and the clinical benefit of the minimally invasive clot evacuation still requires further investigations. This is not the case with cerebellar hemorrhage, where this can represent, indeed, in most instances, a neurosurgical emergency, and therefore this patient should undergo surgical removal of the hemorrhage as soon as possible. Sometimes there may be a need for additional intervention. To conclude, there are pending trials. These are two of many. One that will re-explore the potential value of recombinant factor 7 in the first 2 hours following brain hemorrhage, and the Interact 3, where they will be a early intensive approach within the first 6 hours from onset in controlling or in lowering blood pressure, as well as maintaining certain control of blood sugar, fever, and in the case of anticoagulation, reversal to an INR of less than 1.5. So to conclude, this is the second most common form of stroke. Arterial hypertension remains the main risk factor. CT remains the imaging modality of choice for the diagnosis of acute intracerebral hemorrhage. Reversal of anticoagulant therapy is critical in cases of oral anticoagulant associated intracerebral hemorrhage. And thus far, the landmark randomized clinical trials have not shown benefit of surgical intervention compared to medical management in patients with supratentorial intracerebral hemorrhage. My apologies if I exceeded my time, but again, thank you for your kind invitation, and I wish you a very successful meeting.